Welcome everyone to today's session of our NOW program educational webinars. Today's topic will be IDH mutant gliomas. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the NOW team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the Q&A feature throughout the session. At the end of the session, your questions in the Q&A or the chat will be used to moderate. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit us at www.dana-farber.org/resource center or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Dr. Gonzalez Castro to introduce our panelist. Thank you.
Thank you so much. Welcome everyone to a new Neuro-Oncology Wellness educational webinar. As you know, the Neuro-Oncology Wellness Program is an initiative from the Center for Neuro-Oncology at the Dana-Farber Cancer Institute with a mission to educate patients and their caregivers about brain tumors, as well as provide resources to promote overall health and well-being. I am Nick Gonzalez Castro. I'm a physician scientist here at the Center for Neuro-Oncology, and I care for brain tumor patients, as well as I'm active in basic and translational research in both glioblastoma and IDH mutant gliomas. I also have the privilege of serving as director of the Neuro-Oncology Wellness Program, the NOW program. And today, I am joined by my friend and colleague, Dr. Gilbert Youssef, who is here to discuss with me IDH mutant gliomas. Dr. Youssef is a neuro-oncologist at the Dana-Farber Center for Neuro-Oncology and an associate neurologist at the Brigham and Women's Hospital. He cares for patients with brain tumors and patients with neurologic complications of cancer and its therapy. In addition, Dr. Youssef is active in research that is looking to improve the neuroimaging assessment of response to brain tumor therapy, having contributed to several studies in this area. Dr. Youssef, thank you for joining us today.
Thank you for joining, and thanks everyone for joining as well.
Before we start, I want to remind everyone that this is a live webinar and that we want you to be part of the conversation by submitting your questions using the Q&A feature at the bottom of your Zoom screen. We will select a number of questions at the end of our discussion to review and discuss with all of you. So let's get started. IDH mutant gliomas is a very interesting topic, very near and dear to our hearts. But I thought I would just take a moment to orient our audience as to what these tumors are and how do they develop. So let's start by defining a few terms. IDH stands for isocitrate dehydrogenase, and this is an enzyme, so a small molecular machine that is found in all of our cells, and has a very important role in helping produce energy for the cell. At times, the instructions to make these small molecular machines, these enzymes, can be defective, can be altered. And this is what we call a mutation or an alteration. And these mutations can develop in germ cells, in cells that are involved in reproduction. And in that case, the mutation is present in all cells of the body. But in the case of the IDH mutant mutations, in most cases, these develop in somatic cells, so cells that are part of the body already. And this mutation specifically develops in IDH mutant gliomas in a subset of brain cells that give rise to cells that make up the structure of the brain, particularly helping cells in the brain. These are the so-called glia, which is a Greek word that stands for glue, is the glue that keeps all the neurons and all the other elements of the brain together. This mutation in this enzyme IDH can give rise to a glioma, which is a tumor that develops in the brain. It's a primary brain tumor and can, depending on the type of glioma, can further infiltrate beyond the area where it generated. So the significance of this mutation, this IDH mutation, is that unlike the normal enzyme that has a role in metabolism, in helping feed the cell. The mutant enzyme gives rise to a substance that modifies the way the blueprint of the cells is read. The DNA molecules are rubbed very tightly. It's about 6 feet of DNA that we have inside each cell. And to be able to store it inside its cell, it needs to be wound very tightly around some specific proteins. And the abnormal substance produced by the IDH mutation changes the way the genome is opened and is made available for reading and generating new proteins. So this gives rise to abnormal cell activity that leads to cells that divide more rapidly and tend to activate other pathways that lead them to migrate and form tumors. That is why we think it's so important to understand the presence of this mutation and how to counteract it, because it's essentially the initial step that gives rise to this type of tumor. Another thing that is important to take into consideration is that who are the patients that are affected by these tumors and how common are these tumors? And maybe Dr. Youssef, perhaps you can tell us a little more about this.
Of course, thank you. So gliomas in general, not just IDH mutant gliomas, are one of the most common types of primary brain tumors that we encounter in the brain. And by primary, I mean that tumors that started in the brain and grew in the brain rather than the counterparts that might have started in the body and spread to the brain. But although they're the most common type of brain tumor, they're still rare tumors compared to the other types of tumors that we encounter in the rest of the body, like breast or lung or so. And IDH mutant gliomas, or the IDH mutation, is only found in about 10 to 20% of all cases of gliomas that we encounter. We don't know exactly like the exact incidence or prevalence, but let's say about every year we have around 20,000 cases of new cases of gliomas that are diagnosed, and 10 to 20% of these are like IDH mutant gliomas. Now, gliomas in general can affect all ages, but the IDH mutant gliomas in adults typically occur in patients who are in their 30s or in 40s. But that does not only encompass this age range, and patients can be affected at any age, and also pediatric or children can also have an IDH mutant glioma as well.
Thank you for clarifying that. How do patients come to learn that they have an IDH mutant glioma? What are the most common symptoms? How do these patients present?
Thank you. So there's a variety of symptoms that the patient can develop, and it's the same patient or like not one tumor that can be present in like a similar tumor that can be present in two patients might have different presentation. By far, the most common presentation in patients with IDH mutant glioma is seizures. Typically, patients present with an abnormal shaking or of an arm or a leg, or they can be present with like abnormal sensations, abnormal smells. Even sometimes this can manifest with problems with speech, or really also with what we call a grand mal or generalized tonic-clonic seizure, and this depends on what the location of the tumor. But there are also other symptoms, and these symptoms are really various. They vary from like headaches to progressive weakness or progressive numbness. Typically, these symptoms, the weakness or the numbness, involve one part of the body or one side of the body rather than the generalized or like the whole body. And with time, sometimes some patients might develop some confusion. And typically, these symptoms are progressive and can evolve over time if the patient does not seek medical advice. But however, more often, or like often, I would say, a lot of times these patients can learn about or we can identify brain tumors in their brain if they get a brain MRI that's not really related to any of these symptoms. For example, a lot of times we can have patients having some migraines, for example, or might have been involved in a car accident, and they get a brain imaging, and this imaging would show an incidental mass that had not been causing any symptoms up until that diagnosis.
Thank you for outlining all the different ways that we come to learn about a diagnosis or a patient likely to have an IDH mutant glioma. I would like to stress the fact that we are seeing more and more patients that have MRIs done for other purposes, as you note, and the MRI reveals a lesion that is then biopsied or resected. And also the issue of seizures, which are very, very common in this patient population. I would estimate that between 60 to 80% of patients with IDH mutant gliomas either present with a seizure or go on to develop seizures over the course of the disease. And seizures can have a serious impact on quality of life. And we're fortunate in this day and age that we have several medications that are very effective to control seizures. So patients go on to have, frequent focal seizures or sometimes generalized seizures, as Dr. Youssef was outlining, to having no seizures whatsoever, which is a great outcome. And these medications are very well tolerated. So I would encourage all the viewers out there or folks that review this program later on that discuss seizure management with their neuro-oncologist because it's an important goal to get seizures under control here. Dr. Youssef, what happens after a patient arrives at the hospital, let's say after a seizure or maybe a fall that led to some brain imaging? What imaging studies should be obtained and what are the next steps for patients?
Sure. The first thing is we want to make sure that the patient is stable, meaning if they're having a seizure, we want to make sure to control the seizures, make sure that the patient is able to breathe on their own. The patient does not have any risk factor for aspiration, for example, especially in the case of generalized seizures. And as you mentioned, Dr. Gonzalez Castro, we often start them on some anti-seizure medications to abort these seizures. But any patient who presents with a first-time seizure, there's something that's causing this seizure. And typically, we need to get some type of brain imaging. In the emergent settings, sometimes we don't have access to a brain MRI and we can get a head CT. But by far, the best modality that we have for the brain is the brain MRI, as it helps us see the brain in more details and help identify any lesions, especially small ones, in a better detail as well. And typically, we like to get the brain MRI with contrast or with a dye because the dye can help visualize the tumor a little bit better. Now, IDH mutant gliomas, particularly, the way they present is typically what we see as a mass that's kind of occupying a part of the brain or a space in the brain, and it can be causing some what we call mass effect or a pressure on the adjacent brain. Sometimes this mass is very well identified, and sometimes it's a little bit has blurry margins and more diffuse. And it depends on how the tumor, how early it is or how aggressive it is as well. Sometimes this mass can take up the dye, although in IDH mutant gliomas, not all of the tumors will take up a dye and light up on the brain MRI. Nevertheless, we always like to get the contrasted MRI just to try to learn more and catch all the characteristics of the tumor.
Thank you. So a patient comes in after a seizure or after another event that leads to brain imaging. The imaging that needs to be obtained is an MRI brain with contrast, as you outline. And in this day and age, at least here in the U.S., most hospitals are equipped with the MRI machines and can obtain this imaging. And then a lesion is observed there. So what are the next steps in trying to get to the diagnosis? Who might the patient meet in the short interval after this MRI is done?
Of course. I would say first the patient might have met a neurologist or a neuro-oncologist just for evaluation of the seizures and to treat the symptoms. And sometimes, in addition to the anti-seizure medication, we might start them on some dose of steroids to help with the symptoms as well. But the next step is to actually have them meet with a neurosurgeon, because the next step would be to actually consider a surgery, both for diagnostic purposes to know what we are really dealing with, and second, for therapeutic purposes because if this mass is causing some pressure on the brain and symptoms, doing the surgery and removing this the tumor helps with controlling the symptoms as well. And this actually constitutes the first step of treatment in IDH mutant gliomas. And the goal of the surgery is to achieve what we call a maximal safe resection, meaning that we would like to take as much as we can out of the tumor out of the brain. Ideally, we would want to take it all out, but this also might come at the expense of patient having some deficit. So the surgeon always have to think about like a balance between the benefits and removing more tumors, but also not causing more deficits due to or because of this wide resection.
Thank you for reviewing that, Dr. Youssef. As you mentioned, surgery is always the next step. We need to look at the abnormal cells under the microscope to really get to this diagnosis. Not only we need to look at them under the microscope, we need to do additional studies to confirm the presence of the IDH mutation or other alterations that these tumors might have. And as you note, maximal safe resection is the necessary first step, if feasible, for these patients. The question comes up all the time, is it possible to remove the whole tumor during an operation? And as I alluded at the beginning, these are infiltrating tumors. And not only they develop in one area of the brain and grow there, but they can also extend into other areas. So in fact, it's not possible to eradicate the tumor with surgery alone. Even if the MRI looks quote unquote clean after the operation and there's no evidence of lesion remaining, we know for a fact that if we had the opportunity to review the whole brain and the edges of the resection cavity, we would see abnormal tumor cells. So this calls for the need to use other therapies beyond surgery to try to control the tumors. And what are, in a general sense, Dr. Youssef, what are these additional therapies? What do they involve? What do we discuss with patients when they meet us in clinic?
Of course. So typically, whenever we have brain tumors, we have some tools to fight it and to treat it. And as you mentioned, Dr. Gonzalez Castro, a lot of times we, unfortunately, we cannot eradicate these tumors, but we can at least help keep them under control for as long as possible with these tools. And typically, these tools include, beside the surgery, they include radiation, and they include some sort of what we call systemic therapies, which are oral therapy or therapies that are either like pills or IV or infusions that would help control the tumor. Sometimes we use a combination of these two, or sometimes we use only like one modality at a time. Now, typically, for the past few decades, the treatment of gliomas, IDH mutant gliomas in particular, mainly consisted of radiation plus chemotherapy. And the type and the dose of the radiation and the type and the length of the treatment with chemotherapy depends typically on the what type of IDH mutant glioma we're dealing with and what grade of glioma we're dealing with as well. And this has been the practice and what we call the standard of care practice that has reigned over the past few decades. And the choice of whether to also be aggressive in the treatment with radiation or chemotherapy or so also depends on how the patient is feeling, whether the patient has any symptoms or not, and how well the surgery was. But with recent years, especially the past decade or so, and we have acquired or we have developed new therapies that target this specific IDH mutation that you described in the beginning. And we know that this IDH mutation is actually what drives the tumor and what leads to the tumor growing. So one thought is that if we can block this mutation, then hopefully we can actually block the growth or slow down the growth of the tumor. And this can be achieved with drugs that we call IDH inhibitors, which are oral drugs, actually. And these drugs have been studied for the past decade extensively in IDH mutant gliomas of all grades. And this has led to a large study that was actually published 2 years ago, that showed that using IDH inhibitors in patients with IDH mutant gliomas of grade 2 led to improvement in the control of the tumor and also in the survival of the patients. And this has led to the approval of the IDH inhibitor, and particularly a drug that we called vorasidenib, or the brand name is called Voranigo, in these patients. And this is something that we can potentially consider for patients, particularly who have a grade 2 IDH mutant glioma, and particularly patients whose tumors do not enhance, meaning that do not take up the dye or the contrast on the brain MRI, because we have seen that this is the perfect case scenario for a benefit from this class of drugs. So although like in the past few decades we only had radiation and chemo, now we have in addition the option of using IDH inhibitors. And in some patients, and the right, if we have like the right circumstances, we can actually start with the IDH inhibitors alone and defer the use of the radiation and the chemotherapy. And as long as the IDH inhibitor is working, as long as the tumor is stable, we don't have to actually change the treatment or consider the radiation at that point.
Thank you for that terrific overview of all the options that we now have available to treat IDH mutant gliomas. What is your thought in terms of, the effectiveness of these therapies? What is it that we're trying to achieve when we treat patients with the whole suite of treatments?
Of course. So as you mentioned, because these tumors are diffuse, not only surgery is not curative, but unfortunately with the therapies that we have so far, we have not been able to achieve a cure to kind of eradicate the tumor for good. But the goal with these therapies is to at least keep the tumor under control or at bay for as long as possible, but also improving the survival of the patient overall. And all the studies that were done, whether on the radiation, chemo combination, or also the IDH inhibitors, these studies led to showed that these interventions actually improve something that we call progression-free survival, meaning that the time from the diagnosis until the tumor actually grows in size, meaning that these drugs actually, or these interventions, help keep the tumor at bay and slow down its growth for as long as possible. But also, we know that if we take two patients, we treat one and the other, two patients with the same tumor, one is being treated with some therapy and the other one is not treated at all. We know that patients who are treated usually have a better overall survival or longevity of their survival as well.
Thank you for mentioning that. We have a number of treatments available and the importance of sequencing them in the best possible way. You mentioned IDH inhibitors. We're all very excited about this new tool on the toolbox to treat these tumors. And in fact, the Center for Neuro-Oncology here has been very involved in developing the studies and conducting the studies that led to the approval of vorasidenib. As you mentioned last year, in August of last year, this is a relatively recent development. And the important thing to highlight here is that these are drugs that are well tolerated by patients. When we discuss chemotherapy with patients, we're usually reviewing a long list of expected side effects, and many of them come to fruition. Nausea, vomiting, decreases in blood cell counts, white blood cells, red blood cells, platelets. We see those things often. However, IDH inhibitors, vorasidenib, and an earlier drug called ivosidenib that is approved for other indications, not for glioma, but we had used it in patients with IDH mutant gliomas in the past, are very well tolerated by patients. These are daily drugs that are taken for many months and oftentimes years. So that's a great benefit as well. You're very interested in imaging, and you mentioned that if we go back 5 years when we don't have IDH inhibitors available, patients would get radiation oftentimes. And can you discuss a little bit, changes that we see on MRI after radiation and how to think about those in terms of, Is this tumor growth or what else could be accounting for those changes?
Yes, this is a great question. So we know that radiation is a very effective type of treatment for a lot of brain tumors, including gliomas. And the way that radiation works is that it kills the actively dividing cells, which are the tumor cells. And when it kills these cells, there's going to be a lot of cell debris that actually need to be cleaned. And the way to clean them is to actually have involved the immune system, and the inflammatory cells or the immune cells will kind of act as a scavenging system to just remove the debris of these cells. But this in turn can lead to some inflammation that sometimes could be exaggerated and cause a lot of swelling and changes in the brain. And typically, what we do in the treatment of patients with gliomas is that we get a brain MRI about 4 weeks after the radiation. We wait a few weeks because we know that there's going to be some radiation, and we wait for this radiation to kind of subside a little bit because we can actually see this radiation on the brain MRI. And although the brain MRI is the best modality that we have so far for the diagnosis and the follow-up of the patients with brain tumors, it's still not a perfect modality, and it doesn't really tell us exactly what's going on. And we know that inflammation caused by the radiation or by other treatments as well can look exactly the same as a tumor on the brain MRI. And more often than not, the first MRI that we get after the radiation can be confusing. We can see some changes, and these changes do not necessarily mean that there's a tumor that's growing, because typically this is the main concern that we have in patients with brain tumors. But it can also mean or suggest that there might have been some inflammation or what we call pseudoprogression or a fake progression of the tumor that is going on. Now, we do have some signs or to kind of help us increase the sensitivity or like the probability of these changes being actually related to the radiation or inflammation rather than being related to the tumor progression. And these signs are meaning confinement of these changes in the what we call the radiation field, meaning where the radiation waves were or X-rays were targeted. Also, we know that this inflammation is mostly often occurs mostly in the first few weeks or months that follow the radiation, and then eventually it subsides. So if we get a brain MRI only like 1 or 2 months after the radiation, we see everything that's changes that's only in the radiation field, and it's still kind of a short interval from the completion of the radiation. Chances are that these could be pseudoprogression or inflammatory changes. Although in medicine, there's no 0%, there's no 100%. So there's no way to really be 100% sure that there's no tumor at all that could be also contributing to the changes. And by far, the best way to actually know is to do surgery. And to really know, like look under the microscope, whether there is a tumor growing or whether there's inflammation. But obviously, surgery is a big procedure, and we don't really put every patient through one, especially if the patient is clinically stable and do not really have other symptoms. And in this case, we do have some other approaches that we can consider that are alternative to surgery to actually help us kind of really narrow it down to whether this could be progression or could be inflammation. One of these approaches is to get a short interval brain MRI, meaning that we get a brain MRI about 4 to 6 weeks after this MRI that's showing some changes. And because we know that these changes eventually should stabilize or improve over time, we should see this reflecting on the next MRI, and we should see these changes kind of either stabilize or improve. Because if these changes represent a tumor, this will continue to grow, as we know tumors are usually, once we see some growth, they tend to be more aggressive. Now, other modalities that we can use are some special sequences on the MRI. One of them we call perfusion. And this perfusion allows us to really know what the blood flow that we see on each area of the brain. And we know that if there's a tumor that's growing, it needs a lot of oxygen, a lot of blood supply, and then the blood flow will actually be increased in this area. Whereas if it's not a tumor, we don't necessarily see this. And we also have some other modalities that are now being developed, especially in Europe, but hopefully we'll get the FDA approval done here in the US soon. And this is a particular type of PET scan that uses a amino acid tracer that would and this amino acid actually will be deposited in the areas that require a lot of energy to divide and to grow like a tumor. But let's say if we don't see any changes, whether it's the progression or not, typically what we should expect, and the goal from the radiation and the chemo is to make sure that the tumor does not grow. Sometimes we can see some shrinkage of the tumor, but as long as the tumor is not growing, this means success.
Thank you for that very comprehensive answer. I would say also that there's a technique that we can perform with our radiologists at the Brigham and Women's Hospital, which looks into trying to detect this abnormal substance produced by the mutant IDH enzyme. This is called magnetic resonance spectroscopy, or MRS. And this is something that we can order to try to get additional information. Oftentimes doesn't give us the answer because it's a complex technique, and we need to find an area that is relatively large to perform this study on. But we have a number of tools, imaging tools, that allow us to make an assessment of not only if there are changes in the area of the tumor, but also what these changes might represent. MRI is so important. Dr. Youssef alluded earlier that IDH inhibitors have been approved by the Federal Food and Drug Administration for the treatment of low grade or grade 2 IDH mutant gliomas. But some of our own research has shown that perhaps even grade 3 tumors that do not have any gadolinium uptake might respond to this treatment as well. And some of those patients can benefit from those treatments as well. So let's take a minute now or a few minutes to review some questions. That we have several in the Q&A, and let's try to go through them. Is there a connection between IDH gliomas and exposure to environmental factors like exposure to high radiofrequency / radar radiation, hexavalent chrome, industrial chemicals, or benzene in aviation and marine fuels? Do you want to take a stab at that, Dr. Youssef?
Yes, of course. This is actually a great question because we have always been active in trying to identify what we call risk factors for the development of brain tumors, particularly gliomas. And a lot of extensive studies were done. And the only well-established, I would say, risk factors for the development of glioma is a prior exposure to ionizing radiation. Ionizing radiation does not mean like the regular chest X-ray or like the scans and so on. It's just like irradiation. One particular example is that if a patient was diagnosed with leukemia when they were a child and they had radiation to the brain as part of the treatment for leukemia, this can put them at risk of developing gliomas on the long run. Another well-established, not environmental, but genetic risk factor is what we call familial genetic predisposition syndrome. And this typically occurs in patients who have a germline mutation that runs in the family that puts them at risk of developing, at increased risk of developing brain and other tumors as well. But so far, we don't have like any other well-established environmental or dietary risk factors among the ones that were mentioned or others.
Thank you for clarifying that. It's a very common question, and I spend a lot of time with patients providing reassurance because everyone is worried that perhaps they were using their cell phone very often, or they were waiting for the lunch to be warmed up in front of the microwave every day, and they think that this might have led to the development of the tumor. We have no evidence that that's the case. Only ionizing radiation, high energy ionizing radiation, like the one we use to treat brain tumors, has been associated with the development of future brain tumors. We have a related question, and the question is, are there any long-term side effects from the treatments you're discussing?
Yeah, so let me start by the IDH inhibitors because this is the easiest one to discuss. And because the IDH inhibitors have been in a way recently developed compared to the radiation and the chemo. We don't have like a very long follow-up to well establish like whether there might be long-term side effects. But from what we know and the way it works, we know that this, at least on the short term, or while the patients are taking them, they're fairly well tolerated. They don't cause a significant damage to the organs of the body. And but obviously we'll have to wait and see whether there might have been whether this can be associated with long-term side effects. Although just from the way it looks, and given that the IDH mutation is only present in the cancer cell and not like in the whole body, maybe this is I hope that the risk of having long-term side effects with the IDH inhibitors would be low. Now, when it comes to the radiation, the most common long-term side effect of the radiation, I would say, is cognitive problems or problems with memory, problems with what we call executive functioning. And typically, this manifests with patient initially starting to kind of forget small details or recent conversations. And this can be a little bit, can develop into a more severe or significant damage of the memory. And these typically occur years after the radiation is completed. Although the radiation stops working, like if we get like 4 or 6 weeks of radiation, we know that the major effect of the radiation is done, but the totality of the effect is not really, the radiation can still be active for a long period of time and can still cause some damage in the brain and killing the healthy brain cells, particularly around the tumor. Now, as for the chemo, the chemotherapies that we use, the most side effects occur in the short term, especially when the patient is getting the chemo. Although there have been reports of potentially some chemo-related leukemias or hematologic malignancies that occur years after the patient receives chemotherapy, but these are very rare to occur.
Thank you for mentioning those. In summary, we think IDH inhibitors, which are targeted therapies, are aimed at only disrupting the activity of the mutant enzyme in the tumor cells, have a very benign side effect profile. We follow labs on EKGs from patients early on, but most patients tolerate this treatment. Sometimes there's a little bit of elevation of liver enzymes. We can lower the dose, and the effect is reversible, stopping treatment. Radiation over time can cause changes to brain function, particularly in regards to cognition, of thinking and memory, concentration. And then chemotherapy can cause acute effects, as we mentioned earlier: nausea, vomiting, decreases in blood cell counts. Over time, some of the chemotherapies we use can have other toxicities, such as pulmonary toxicity. So some of you at some point that received treatment were probably doing lung function studies as well. So all these should be discussed very carefully before starting therapy. There's another related question to that, and the question is, are there any approved or pending stem cell treatments in the pipeline to help us build new neural pathways to recover from neurologic effects of chemo and radiation? This is a patient that is noting a history of fatigue, weakness, and some cognitive problems. What are your thoughts on that, Dr. Youssef?
Yeah. So the fatigue in the treatment of glioma is a very heavily studied symptom. And there have been multiple approaches or trials to actually address this symptom along with the other symptoms as well. And so far, we don't have like significant or I would say robust data supporting one agent, like a pharmaceutical agent, let's say, to be used. We know that exercise is by far the best way to actually fight this fatigue. Now, in regards to the stem cell research, I'm not aware of any kind of such a research where stem cells have been helpful in actually either in the treatment of fatigue and so on. We know that like stem cell transplant, for example, which is a different type of treatment, can sometimes be used in some sort of brain tumors aggressive brain tumors that occur in pediatric patients, but not the IDH mutant gliomas. But when it comes to IDH mutant gliomas, at least for now, stem cells have not been or do not have a role in the treatment or the management of the symptoms.
Yes, I would like to stress that point, that exercise is the most effective way to combat fatigue in cancer in general and also in brain tumor patients. And it's also the most effective way to preserve cognition. I have a personal interest in exercise and the use of exercise in oncology. And in our Now website, you can find a two-part series on exercise for brain tumor patients. So if you go to now.dana-farber.org, you should find those videos there. But I encourage all my patients to at least meet the Surgeon General's recommendation in terms of exercise, which is to do 20 to 30 minutes of moderate intensity aerobic exercise, which can be accomplished by walking at a slightly brisk pace and adding 2 to 3 days of strength exercise. You don't need any weights. You can just use the resistance training to accomplish that. So I strongly encourage all patients and all caregivers and everyone to take on an exercise routine if you don't have one already. The next question is about the use of IDH inhibitors. And the question is, do IDH inhibitors work with recurrent tumors if recurrence is after 20 years of remission? What are your thoughts on that?
So,
and I will couple it with another question that we have that says, can IDH inhibitors be used after radiation and chemotherapy? Which was likely the case of this viewer that asking about a recurrence after 20 years.
Yes. So there's a lot of questions. So IDH inhibitors, because now there's a lot of interest in them and there's a lot of questions that are still unanswered. But what we know so far about these inhibitors is that as of now, as per the FDA, it's approved for treatment of grade 2 tumors, especially the newly diagnosed ones. We don't know whether earlier studies show that maybe patients who have a recurrent tumors or progressive tumors that IDH inhibitors might not really work. But from our institutional experience and our clinical experience, we have used IDH inhibitors in patients whose tumors came back, especially I would say like 20 years after a remission, if the tumor remains of a grade 2 or a lower grade, if the tumor remains of a non-enhancing, it doesn't take up the dye, there's always a room to potentially consider the IDH inhibitors as one of the options to treat this recurrence. And now the other question regarding patient has a newly diagnosed glioma, has just finished treatment with radiation and chemo, whether should they switch to IDH inhibitors and kind of like remain on a maintenance treatment rather than remaining on observation. And I would say this is yet to be studied. It's unclear whether staying on the IDH inhibitor might be actually beneficial or helpful, and whether it would lead to superior results compared to like being on observation. And there are active studies and active trials actually that are ongoing or will start hopefully in the next couple of years that will help answer this particular question.
Thank you. The next question is about CAR T therapy or CAR T cell therapy, if this can be used again after progression. In fact, this is a very active area of investigation, and we have seen several studies looking at the use of CAR T cell therapies for the treatment of glioblastoma, which is a different type of tumor. It's a tumor without an IDH mutation, so-called IDH wild type tumor. And these therapies are being studied in that setting. We don't have yet a CAR T cell that has been designed against IDH mutant tumors, but we expect that will happen in the near future, and we'll learn about responses at that time. But that's a very interesting and promising area of research. What are the implications to prognosis of IDH mutant versus wild type? I don't know if you want to discuss that, Dr. Youssef.
Of course. So We know that IDH mutant gliomas in general are behave better than their IDH wild type counterparts. When we take like grade by grade, like side by side, grade 2 or 3 or 4 or whatever. So at any grade, regardless of what it is, the IDH mutation helps or leads to a better prognosis. Even if we are talking about a tumor that has a grade 4, that's a grade 4 but does have the IDH mutation, these tumors actually behave better than a grade 2 without the IDH mutation. So this mutation actually confers a better behavior and a less aggressive or more benign behavior to the tumor.
Thank you. There's a question also from a participant asking about the case of glioblastoma. As we mentioned at the beginning, this is a different tumor. The question is about the appearance of areas of contrast uptake or dye uptake after treatment, what this could represent. And as we mentioned earlier, this could represent perhaps a new area of tumor growth or perhaps the effects of radiation. And this is commonly seen in glioblastoma. We cannot, unfortunately, provide any specific patient advice. For anyone interested in a consultation with one of us or one of our colleagues, we encourage you to contact the Center for Neuro-Oncology, and the number is on the website, and we can discuss the case specifically then. A couple more questions that we have. Do you ever see hyperprogression response from tumors after using an IDH inhibitor in an otherwise stable grade 2 IDH1 mutated tumor? Have you encountered that, Dr. Youssef?
Personally, I have not, although there have been some reports of maybe having a hyperprogression. Hyperprogression meaning a progression that might be exaggerated, but these have been very rare case reports, and some of these patients had a hyperprogression, and then the tumor kind of started responding to the drug or like to the IDH inhibitors, but I have not seen one personally.
I haven't either, and I have heard of this report. So I think that the key issue here is to follow up these patients closely with imaging to see the trajectory of the imaging findings. And then there's a question about coupling inhibitors with vaccines for IDH mutant tumors. There is an effort to do that, and some of our colleagues in Germany are studying a vaccine against the most common mutation in IDH mutant gliomas, the IDH1 R132H mutation. So those studies are ongoing, and hopefully we'll have more information to give you at a subsequent program. Can you explain the difference between IDH1 and IDH2 mutation? So IDH is an enzyme that comes in a few different forms, IDH1, IDH2, and IDH3. And most patients that develop a glioma have a mutation on the IDH1 form. Some patients, although it's relatively rare, around 5% or less of patients have a mutation in the IDH2 enzyme. So we encounter that less frequently. The FDA-approved drug, vorasidenib, can inhibit mutations in both IDH1 and IDH2. I have another question. Can artificial intelligence help speed up the process of learning the effectiveness of potential useful treatments? What are your thoughts on that, Dr. Youssef?
Yeah, I would say this is a very interesting question, and obviously AI is gaining interest, a lot of interest in the field of medicine. I'm not sure of like how, at least now, I cannot see how artificial intelligence can potentially uh, um, help improve the clinical kind of or like usefulness of the treatment. Maybe in some ways, artificial intelligence in the treatment of glioma can involve MRI reads, for example, make the MRI reads more kind of less biased and more efficient. And now artificial intelligence is also being used in pathology as well. And maybe it might be one way of like also be helpful is kind of screening for some mutations that can be targeted. But I'm not aware. I don't know like if like at least now if this would help kind of help us learn about whether a treatment would be effective or not. I don't know what you think.
Thank you. No, we welcome all kinds of intelligence in our fight against brain tumors. So I think a lot about these. Dr. Youssef does too, and many of our colleagues, but we're seeing some exciting tools coming along that might help us in our work and in caring for patients. Another important question here, does every grade 2 IDH1 mutated tumor inevitably progress to something more aggressive, even after many years of stability? And then a related question is, can an IDH mutant recur not as IDH mutants or as IDH wild type, or once IDH mutant, always IDH mutant? So yes, grade 2 tumors can progress over time. We know that this is part of the expected behavior of these tumors. And when they recur, they most often remain IDH mutant tumors. There are some rare cases where biopsies have been obtained at the time of recurrence and the mutation has not been found, but these are exceedingly rare. Most of the time, the IDH mutation is preserved. The problem is that as tumors evolve, they pick up other mutations that make them more aggressive. Mutations that can function independent of the activity of the IDH mutation. And this is what confers the more aggressive behavior. So I think we have covered the questions we have. As I mentioned earlier, for any additional questions, specific questions, we're happy to meet anyone for a consultation. And as we wrap up, Dr. Youssef, do you have any final thoughts that you would like to share with our patients?
First, I would like to thank everyone who joined. And my thoughts are that we have come a long way in the treatment of gliomas, and we're always making progress. And this progress could not have been made without our very motivated patients. And I would always like to thank our patients who participate in clinical trials, and also for bringing up all these important questions and the different aspects of tumor. And I would say that for all of you, whether you are patients or patient caregivers or friends of patients, we're in this path together, as this relationship between physician and patient should be, we like to be very strong, because together we can achieve actually the best or like some of the best treatments possible.
Thank you, Dr. Youssef. I echo that. We're so grateful to our patients over the decades that have helped us, build the knowledge that we have today to care for this disease. And I am very excited about recent developments, and both in diagnostics and in treatment and treatments that we have on the pipeline. So I encourage you to discuss all this with your treating physicians.
But I just want to thank you both for this great presentation. And as I mentioned earlier, the session was recorded and it will be posted on our Blum YouTube playlist. So please keep an eye out for that.
Thank you, Dr. Youssef, again, and thank you everyone for joining us. We'll see you next time.